Good morning, and thank you for joining us today. As you are aware, sorry, Newfoundland and Labrador has its first probable case of monkeypox. First, I think it's important that I give you an idea of what the definition of a probable case is. So a probable case for us is defined as a person of any age who presents with an unexplained acute rash or lesions and has one or more of the following: has an epidemiological link to a probable or confirmed monkeypox case in the 21 days before symptom onset, such as a face-to-face exposure, including health workers without appropriate personal protective equipment, direct physical contact, including sexual contact, or contact with contaminated materials such as clothing or bedding, or reported travel to or residence in a location where monkeypox is reported in the 21 days before the case's symptom onset. Since the first onset of cases throughout the rest of the country, public health in our province has been preparing. As with any virus, we recognize it is only a matter of time before it enters our sphere. Education is always an important tool in the public health toolbox, and that is why we are focused on ensuring that healthcare providers and the public know the symptoms. People usually develop symptoms 5 to 21 days after being infected with the monkeypox virus. Symptoms usually occur in 2 stages. In the first stage of the virus, one may experience fever, chills, swollen lymph nodes, headache, muscle pain, joint pain, back pain, and fatigue or exhaustion. In stage 2 of the illness, a rash typically develops, usually within 1 to 3 days, sometimes longer, after the fever develops. The rash often starts on the face, arms, and/or legs, but can affect other parts of the body, such as the hand, the feet, mouth, genitals, and the anal region. The rash progresses from raised red bumps to blisters to pustules and then scabs over. Scabs fall off, leaving new skin. Monkeypox presentation during the current outbreak may not present with the classical symptoms and sign, and an individual could potentially have a rash before the fever or have just one lesion in the genital or anal area rather than multiple lesions on other sites in the body. An individual is considered contagious from the start of symptoms until the scabs fall off, revealing new skin. This usually takes about 2 to 4 weeks. If you start having symptoms of monkeypox, you should isolate at home and immediately contact your healthcare provider for advice. If you are identified as a contact of someone that has monkeypox and you have no symptoms, you'll be offered a vaccine. Imvimune is the name of the vaccine, and that will be offered to you by a public health official. This post-exposure vaccination may prevent the disease or decrease its severity. You can reduce your risk of becoming infected with or spreading monkeypox by staying at home if you are sick, avoiding direct physical contact, including sexual contact, with someone who is infected or may have been exposed, practicing good hand hygiene and respiratory etiquette, including covering your coughs and sneezes or wearing a well-fitting mask, clean and disinfect high-touch surfaces, and practice safe sex. The current monkeypox outbreak has disproportionately affected the two-spirited, gay, bisexual, transgender, and queer population. The virus is spread through contact in social networks, and international travel, as we all know, has increased. People in the 2SGBTQ+ community are often proactive in protecting their health and getting regularly tested for sexually transmitted infections. This may have helped detect monkeypox early in this community. While most recent infections are occurring in people who identify as men who have sex with men, the virus can affect anyone through close personal contact, regardless of age, sex, gender, or sexual orientation. Our message today is about understanding the signs and symptoms and learning how we can control the spread. It is also one of understanding in terms of those who may need our support, and help and support should they have to isolate. I will now invite questions from the media.
Dr. Seviour, I'm wondering if you can give us more information about where this person got the case. Had they traveled recently and brought it back, or is there a concern that there may be more cases if they acquired it locally?
So I can't really discuss an individual case, but in general, in a province like ours, just like with COVID, introduction is often through travel.
How many cases are currently in Canada? Do you know?
I did know, and when I talked to someone at the interview yesterday, and I will tell you, I think it's 680. Can I get you that information, the correct number? Because I'm going to give you yesterday's number anyway.
Okay.
Yeah.
People who are concerned that they might have this, what sort of options are public health making available in terms of getting tested? I'm thinking especially people who may not have, a family doctor that they can get in to see, for example.
Yeah, so if someone doesn't have a family doctor, then they can call 811 and things will be coordinated for them, and the testing would be done at the hospital.
There's probably, a lot of worry coming from people to hear about, another global health emergency. So, how does this differ from the type of emergency we were in with COVID? Should people have these worries that they're having right now?
And that's a really good question, and I know people are tired, and I know people are saying, oh, not another one, but I think this is different. Plus, I think, we've weathered the first one really well. Newfoundland has done a wonderful job, and really, this is our same goal, is to prevent human-to-human transmission, to interrupt that transmission and spread. But monkeypox is different in that it's an infection that once you get it, you also have long-term immunity, which we haven't had with COVID. Also, we, unlike COVID, we have a vaccine available, which we didn't have when COVID started.
Can you say what that vaccine is?
Yeah, the vaccine is called Imvamune, and it's a vaccine, and it's currently in shorter supply because it's basically been kept, for, against smallpox and developed for smallpox, but it also works for monkeypox since they're in the same viral family. So that's that, and it's been mainly kept in smaller supplies. All provinces, all countries have it, but so now that supply is being ramped up so that we can use it. We have enough here to give people at post contact.
And are people already vaccinated against it? Like, is that part of the ones that children would have gotten?
No, so
Okay.
I think I have the little pock on my arm. Some of us have that little pock on our arm, and I think, I'm not going to say how old I am, but that vaccination stopped around 1972 or 73. Okay. So that we haven't given routine smallpox vaccination since then.
You talked a little bit about the symptoms and the steps that they go through. What does the timeline look like for someone when they are infectious? How long that lasts?
So you are infectious from the time you start having symptoms. If that symptom should be fever, or even that malaise, those what we call constitutional symptoms, and you're infectious until the lesions scab over, fall off, and you know yourself when you get a scab and you get that new skin that grows under it, you're infectious till that point, which is sometimes between 2 and 4 weeks. And my trusty work colleagues have told me that the number is 745 cases in Canada at the moment. And I can tell you that it's in 5 provinces. We will become the 6th.
Some of the other provinces that have had cases have been doing vaccination campaigns targeting the LGBTQ community, people that they consider high risk. Is there any plan to start rolling out vaccinations beyond the close contacts here?
So we'll be having discussions on that and how we approach that. So right at the moment, the vaccine being in short supply has been focused to those areas across the country where they're experiencing outbreaks. That is not our situation here, but and that has allowed for that pre-exposure prophylaxis to be given to people in high-risk communities.
How many doses do we have?
I can't tell you the exact number, to be honest.
Can you explain just how transmissible this is? I mean, obviously, many in the public have become familiar with transmissibility in terms of COVID-19. So, I guess in comparison to that, how transmissible is it?
So certainly in nowhere near
Okay.
COVID-19. We're not dealing with the same situation at all. It takes a really close personal physical contact. The other way it's spread is through if somebody has their lesions or sores and they contaminate bed sheets or linens, then that it can transmit that way. And then through close contact, respiratory cough, sneeze, with prolonged close contact. But I just attended a WHO session yesterday morning, and most of it was through direct physical contact. And there hasn't been much widespread seen outside households or anything like that.
I know you can't speak to where this case had come from, but is there any idea of how many people may have been in contact with the probable case?
And I can't give numbers like that because, and I think I've spoken about before in public health, people give us their private information and we need to guard it, but rest assured that contact tracing is ongoing and those close contacts are being identified and educated and being offered Imvamune.
Can you say generally the region where this case is, as we do with COVID? There's so many cases in this region, Labrador, East, West.
Yeah, and no, and we're not doing that. I don't think it really helps. It doesn't. It's not like COVID. It's a totally different illness. It doesn't really help. And I think, you know, some of our concerns about this is about stigmatization of certain groups. And I think, you know, when you come from a smaller region, it makes people more identifiable, and something we never really want to have happen. People have a right to their privacy and a right to respect about their decisions about how they live their lives.
Given that it does, as you said, disproportionately affected the gay or the queer community, how do you get past that, though? I mean, the numbers speak for themselves as far as how this has been transmitting in Canada. So what's the, you know, how's the struggle with that?
Well, you know, I think we know, and this was discussed at WHO yesterday, that there was circulation in the community before this, right? But that was undetected. And really, once it entered this community, you know, whichever way it did, you know, they tend to have strong social networks, and all viruses love a social network, right? And so, and I think why we picked it up so quickly is because this community is proactive about their sexual health, and they do tend to get STI testing. And so you know, that allows us also to, you know, work with the community to eradicate the disease and to stop transmission. So I'm very hopeful in this, and sometimes when you have it in a, you know, it starts in a community, it always starts somewhere, right? And a virus doesn't choose, it just takes the opportunities it's given. So, you know, in working with the community, you know, we should be able to stop the transmission.
Was there anything that, the WHO session you had yesterday that you mentioned, was this an international gathering? Was it the
Yes.
Canadian?
Yeah.
Okay, so what was your takeaway? What was the significant takeaway for you, you know, with your knowledge of this? Was there an eyebrow-raising moment? Was there something that you probably weren't?
No, you know, I think one of the things that really struck me is that, you know, the first case was in 1972 in a child that had contact with a rodent, an infected rodent, and that it's another viral disease that we're going to learn a lot about. You know, has it changed somewhat? Has there been some mutations? It's certainly not like in the COVID line, which, you know, seems to close every Tuesday. But, you know, has something changed that makes it more transmissible in humans? And also, you know, to me, you see something that was there, that's a long time ago, since 1972. And just the way that viruses sometimes enter our environment, and that we always therefore have to be vigilant, and we always have to be, you know, up on it and educated. And I think what was wonderful about the WHO session was it was people from all across the world, and the African perspective was presented, and an update was given on the cases that, you know, the wonderful sharing that happens in the community on the cases that have been seen. And so there was discussions mainly around that.
Has there been any suggestion, there has been suggestion in Canada by some groups that Canada has been slow to react to this. Did you see any of that from your perspective?
No, and I think that, you know, and sometimes I think that's fair talking. People are worried and they're afraid, and so then they tend to lash out. I think we all do that. But I think, you know, this was not a vaccine, and maybe some of the, you know, is that confusion. Why is Montreal got vaccine and St. John's doesn't have vaccine? When there's outbreaks in Montreal, Vancouver, and as always in Canada, we share where we need it. And I have no doubt that should we need vaccine next week, that I would be able to get it in the quantities that we would need to start our campaign, you know? So I think that's where it comes from, that people, but you don't keep a vaccine for something that's a bioterrorist threat. You don't keep a large amounts, right? But I think sometimes that's just a misunderstanding and fear.
So this case is coming, like last week was Pride Week, so an opportunity where the LGBTQ community would have been doing an extra amount of mingling. How concerned are you that we may end up seeing more spread because of that?
We're obviously going to be watching and you know, and working with the community, but you know, I wasn't really surprised, Peter, that we got a case, and you know, because of activities all across the world, really, and the international travel and how mobile people are.
You just said something I want to clarify. You said bio what threat?
Yeah.
So I think, you know, that smallpox has been eradicated since I think it's 1982, but we keep vaccine because if ever there was a bioterrorist threat. So there are people in the country that have smallpox. So the military would have smallpox vaccination would have continued in that group. But for the rest of us, since it's been eradicated since 1982, so I was born before 1982.
And just to be sure, sorry, that's not how this happened. Or,
oh no,
okay,
no,
right.
certainly not. No,
that's why
certainly
vaccines
not.
are around.
No, so you know, in Africa, This is an illness that happens when, cases are bitten from a small rodent. It's mice, it's small mammals, squirrels, different types of squirrels, and that get or eating of a meat of infected animal that wasn't properly cooked. So that's been the transmission in Africa, and so obviously somebody who got it that way, and then it spread.
You mentioned the infectious period being around 2 to 4 weeks. In other places, have there been any, longer cases or long-term effects beyond, when the rash ends?
No. So that's another thing. I mean, it's not one thing that, because there's two clays, two different ones. There's one from the Congo, there's one from West Africa, one being more severe than the other with a higher mortality. And the Western African one is the one that is now transmitting, and that has milder symptoms. And it's basically once you're finished and the lesions have resolved, you're well again. And so we haven't seen, we've seen hospitalizations for pain because the lesions can be very painful, but very few hospitalizations for other, so it's certainly not as severe as COVID.
And when you and so public health, now that we have the first probable case, what is public health doing, I guess, to share information to make sure people are prepared for this?
Well, thankfully we have you guys, so that's why I'm here this morning. And we have a website which we have launched and launched earlier this week, just in time as it is. And like NTV kindly reached out to me yesterday, just before this, and asked me would I do an interview on monkeypox. So, and we'll keep answering people's questions and giving PSAs to the public, so we can educate them about monkeypox.
So at the simplest level, just what's your advice for people to protect themselves?
So my simplest level, because I'm a public health physician, is wash your hands, and clean those surfaces. The things we've kind of gotten used to at COVID that we're quite good at now, and that if you've been in contact with somebody who has monkeypox, that you follow our guidelines, which are all on our website, that if you think you've had contact, to contact your healthcare provider or to contact 811, and also then to support any family or friends who may have contacted monkeypox, to respect their privacy, to support them in isolation. We all know, there's probably not one person in this room who doesn't know how hard isolation is. We've probably all been isolated from COVID, and to support people in that. And also non-judgmental. I think COVID's taught us an awful lot, how judgmental people were about who caught COVID in the beginning, and then, then there was all of us at some point. So I really want to stress that and Newfoundland does such a wonderful job about supporting people who have a virus and not judging them, and because viruses, they don't make any distinctions. They just find who they can, and that's the bottom line.
I want to ask you, there was a gentleman, Len Tooley, who was on Toronto Star podcast. He contracted monkeypox, and he's been an advocate to sharing information. Yeah. He said on that podcast that he was talking to a Newfoundlander who had been at Toronto Pride, contracted monkeypox, but hadn't reported it, and essentially had just isolated because didn't have a doctor, didn't have an access to be able to, an easy outlet to be able to go and get that information and get tested. How big of a concern is that for you, and can you explain what sort of access public health is going to try and make available for people who may not be sure where to go?
Yeah, and Peter, I'm always sorry to hear about a case like that because, and I know, people can feel a bit paralyzed and not know what to do. So certainly this is one of the reasons why we really wanted to reach out to the press and to the population via the press, and also, why we've also put up the website, so that gives somebody somewhere they can go and get information where they don't even have to speak to anybody. And we also have reached out to physicians, and we've, that's, I think, the first reach out to physicians was probably in May to say, because we need them to be vigilant. We need them to understand monkeypox. I mean, it's not a normal thing you find in Canada, so we really, that education piece is key. And that if somebody doesn't have a physician, that they call 811, and 811 has also been briefed on what monkeypox is and what they should do. And we have great support through the hospital, through our infectious disease specialists, which we're very fortunate to collaborate with also.
Sorry, Peter. How I know that it can in some cases be fatal. I think I read. Just how, what percentage?
So there's been no fatalities in
Okay.
any of the cases in Canada. I think now, and I'm going to pull this out of my head, which is a scary place sometimes, but I think there's been 16,000 cases, and there have been no deaths in the current outbreak. There have been 5 deaths in Africa, unfortunately, and sometimes the concern there is that the healthcare, standard, the healthcare access isn't always the same. But in terms of the current cases, there have not been any death. There have been hospitalizations, mainly due to pain control.
That's 16,000, that's totality? That's total?
Yeah, and I shouldn't pull a number out of my head like that.
Sorry.
Can we confirm that? Well, yeah, that's the total number of cases.
Since it's existed in
I guess, really, the
Oh.
outbreak started in about May.
And currently it's 7...
Oh, 60, you better check that for me.
And currently 745 was the number
Yes, in
from
Canada.
this particular outbreak.
So there's Canada is one country, Europe has been involved, right? Several countries in Europe. The United States has seen outbreaks. So that would be me trying to give you the total number.
I want to ask about reporting. How often is the public going to get updates? Is this a case of, there going to be a weekly, if the numbers increase, are we going to find out about each individual? Is it going to be a weekly update? How will people know if they want to understand how much of the disease is spreading in this province?
So that is something I'll bring back to my group and the executive, and we'll make a decision on that. I don't know. I can't tell you that yet. We haven't thought about that. We've just really thought about first case, need to talk to you right away, and had wanted to talk to you yesterday about that. I'm not surprised that it was coming. So we will certainly let you know about that.
And turnaround on testing compared to COVID? Is it the same sort of time
So
periods?
and it's, and it will be like COVID. Our testing is, I'm sure, is going to get better and better all the time as what we've done with COVID with so many brilliant people in Canada working on something. But right now, any test we do, that goes to the National Microbiology Lab.
And the turnaround for...
So I can't tell you exactly what the turnaround is. I'll be able to tell you in next week.
And so are we developing the capabilities to do tests locally here? Is it just that it has to be verified by the lab as well, or do we not have the capability at all?
So right now, we don't have the capability, but that will be looked at for sure.
Okay.
17,000 worldwide. I was close.
Thank you.
Any more questions?
No, I think that's
Okay. Thank you.
Thanks, guys. Thanks so much.
Thank you.
Thanks, Officer.